Okay, so we're going to go on with our afternoon session here, which is a very exciting session. Includes our keynote speaker, Dr. Hillel. The moderator for this afternoon session is going to be Dr. John Child. I just want to say a word about Dr. Child here before he introduces Dr. Lax. No, don't leave. So yeah, no, he does deserve all the ovations that we can give him, because Dr. Child was the director of the program and actually trained me in adult congenital heart disease, and I really owe so much of what I've done and where I am to Dr. Child and to his mentorship, as many of us do. So Dr. Child retired a few years ago, and it's always great when he comes back and joins us for sessions like these. So thanks for coming back, Dr. Child, and the floor is yours.
All right, sir. Thank you. It's good to hear you clapping. I was afraid it was going to be, what's the sound of one hand clapping? Yeah. And I can't take credit for Dr. Abelhosen. He's done a lot of this on his own. So, it's my pleasure to introduce our keynote speaker. You all know him, Dr. Hillel. He's the Chancellor's Professor of CT Surgery, has previously been the Director of Cardiothoracic Surgery in the Heart-Lung Transplant Program. On a personal note, there are probably about 3 people who were instrumental in what I've learned and my career, you might say, in congenital heart disease. That was Joseph Perloff, Roberta Williams, and Dr. Lax, from whom I learned most of what I know about cardiac surgery and the intricate anatomy seen in, so I have to thank him for what I've learned from him. He's going to speak on adult congenital cardiac surgery, the past, the present, and the future in the next 3 minutes. No, I'm just kidding. Dr. Lax. All right.
Thanks very much. I want to thank Jamil for the opportunity of speaking this afternoon, and I want to express what a great privilege it has been for me since coming to UCLA back in 1982 to work with the Adult Congenital Heart Group, a fantastic group of cardiologists. The program was started, as we all know, by Joseph Perloff at a time when there really wasn't a specialty of adult congenital heart disease, and he established the first clinic. And then working with John Childs and now Jamil and the fantastic group that he has gathered together, including some permanent members like Pam Miner and Linda Hauser and many of the other great people, multidisciplinary groups that are involved in the program. Joe Perloff, it turned out, was a prophet because he predicted the future. He realized back in the late 70s and 80s that congenital heart disease was going to be a major specialty, and that something needs to be done to study these complex patients, not just from a heart point of view, but from a hematologic point of view, a liver, and all the other changes that occur in these complex patients. Cardiac surgery got its origins actually with adult with congenital heart disease, and the very first open heart surgery was done by John Gibbon in 1953. He had developed a heart-lung machine for the treatment of massive pulmonary embolism, and did his first open heart case, which was an ASD in an 18-year-old. He subsequently did 2 more ASDs in 5-year-olds. Both died, and he stopped being a heart surgeon. 1954, Lilly High, who was extremely daring individual, started open heart surgery with cross circulation, and after a year or 2 went over to the heart-lung machine. 50 miles away from Minnesota, at the Mayo Clinic, John Kirkland had developed the Mayo Gibbon oxygenator and began what became the modern era of cardiac surgery. I began my training in congenital heart surgery with Aldo Castaneda at Boston Children's Hospital. This was a most amazing man, and his contribution was to do earlier and earlier complete corrections in the neonate, and was one of the pioneers of the arterial switch operation. He is still alive now in his late 80s, and established a congenital heart program in Guatemala, where he originally came from, and is still active and has made an extremely successful institute for the treatment of children who otherwise would not have had any access to cardiac surgery. I share with Jamil an interest in military history, and in looking at the approach in congenital heart surgery, there is the tactical approach and the strategic approach. The tactical is the art or skill of employing available means to accomplish an end. That is, what do you do to get a patient through a corrective operation? The strategy is the art of devising or employing plans or stratagems towards a longer-term goal, and that is how we stage procedures and how we take into account the long-term goal in adjusting our corrections. I first saw one of the most brutal tactical wars in cardiac surgery when, as a chief resident, Bill Norwood was beginning or continuing his experience with the Norwood operation, and at that time had an almost universal 100% mortality. And to see many of the cardiologists calling for an end of this brutal experiment, and it was actually Aldo Castaneda who continued to support him and help him devise better and newer ways of doing it until eventually they started getting survivors. The first person who really, one of his earliest talks was cardiac surgery from the point of view of an academic cardiac surgeon, was John Kirkland, who, in addition to being a very good surgeon, also applied rigorous statistics to outcomes and ways of doing the operation based on experience. One of the ways that the operation was done early on was with a very large transannular patch. And the VSD was closed through this right ventricular incision. And this resulted in these big aneurysms of the right ventricular outflow tract, as you can see here. And many of our early reoperations were for insertion of a pulmonary valve, in this case a homograft, and resection of this large aneurysm and reduction in its diameter. This is still one of the big challenges for Jamil and Dan Levy in terms of how can they avoid those patients going to surgery and somehow get a valve into them without an operation. And Brian and I have been helpful in trying to come up with hybrid procedures to give them a landing zone, even though it will reduce the number of these operations, which at one time were one of our most common operations. We still saw and still see rarely nowadays, but in the 80s, patients who in their 30s, 40s, and my oldest one was a 65-year-old who had never had a tetralogy repair. This was a 35-year-old patient who had been surviving on a left blaloactasic shunt and a Glenn shunt and had a complete correction with a valve insertion at the age of 35. One of the other challenges which was beginning to get some attention in the 80s was the treatment of patients with so-called tetralogy of Fallot. We now call it pulmonary atresia with ventricular septal defect and MAPCAs, major arterial pulmonary collaterals. And we were faced with this patient at the age of 18 who had a balanced circulation, and we placed a large graft from her ascending aorta with a controlled access into the aorta to a very large confluence on the right. At that time, the treatment of these multiple left-sided collaterals was pretty crude. Some people were sewing Dacron grafts after disconnecting these vessels, and most of them resulted in stenoses. We came up with a procedure where a patch of autologous pericardium was harvested, treated very briefly with glutaraldehyde, and then after dissecting the vessels out into the pulmonary parenchyma, we made anastomosis to the vessel, which you can see here, a long longitudinal anastomosis to try and prevent constriction, and then turned this patch into a tube, which was then connected to a Dacron graft, which you see. And and the Dacron graft was then connected to a shunt to the subclavian artery. These stages were done somewhere between 6 months and a year apart, and was called unifocalization. And then we came back through the front, closed the VSD, and placed a graft to these two vessels. One of the highlights of my career was to be on the stage with Jane Somerville to discuss the treatment of this condition. And her argument was that these patients should be left alone if they're reasonably balanced and not operated on, whereas I was presenting 92 patients who'd had unifocalizations, 58 of them who had gone on to a complete repair. Her response to these lovely slides, which I was so proud of, was that she said this was the greatest example of surgical exhibitionism that she had ever seen. After I had finished my training in Boston, I spent 3 years at St. Louis, where I did children and adult heart surgery and worked on artificial devices, and went to Yale as director of pediatric cardiac surgery. Bill Glenn was still working, although by this time he was doing only an occasional case and was working on phrenic nerve stimulators. But he still followed fairly large numbers of patients whose only palliation was a Glenn shunt. And he used to proudly show me in the clinic that he would lie them down, do a femoral artery stick himself, and show me that the saturation was 78, 79%. The problem, however, was that they were purple with a hemoglobin of 22, 23, and when they walked, their saturations would plummet into the 50s or 60s. But he was someone who had a great conceptual idea for univentricle about separating the two circulations. And before he did this Glenn shunt, he had worked on dogs with all kinds of different connections, SVC to right PA, IVC to right PA, and complete IVC to right and SVC to left. He found that uniformly all dogs who had their IVC diverted all died with venous hypertension and in a low output state. And he thought that the future of complete separation was not going to be possible. Initially, the Glenn shunt was done off pump through a right thoracotomy and was done only to the right pulmonary artery with another source of pulmonary blood flow through pulmonary stenosis or a shunt to the left. And later on, it became the bidirectional Glenn shunt, and although he had not described the bidirectional, his name was still used for it, which I think was appropriate in view of the concept was his. And we did although many people were using bypass and some even circulatory arrest, as in the Hemi Fontan, which Bill Norwood was doing, we used a temporary shunt, which connected the SVC to the right atrium while we did the anastomosis. Francis Fontan had the idea that in tricuspid atresia, where the right atrium was very hypertrophied, he would turn the right atrium into a right ventricle by placing a homograph valve in the IVC and another one in the junction with the left PA and do a Glenn shunt to the right PA. And thus the first Fontan was done in 1968 and published in 1971. Several modifications were developed by people who still felt that the right ventricle was important. This is the Bjork modification, which was done for tricuspid atresia with a ventricular septal defect in right ventricle. And you can see here the flap of right atrium, which was connected to the right ventricle. And there are some patients who develop a connection and get Wolff-Parkinson-White through this right atrial to right ventricular connection. And for surgeons doing redo operations, this conduit is right under the sternum and it's very difficult to reopen safely. And then Bowman, again, thinking of this right ventricle as of potential use, devised a connection in which a conduit with a valve was inserted. Interestingly enough, we have seen some patients who had had previous Bjork or Bowman procedures in which the right ventricle, which was initially quite small, grew to be 50% of normal. So the blood going in and out had dilated the right ventricle. And we did about 3 operations, or 4 perhaps, where we connected the right atrium to the ventricle and placed a very large valve between the two of them. And at least in the operating room, we saw that the right atrial pressure was lower than the pulmonary artery pressure. And in animals, it's been shown that if you can get an RV to 50% of normal, you can get a reduction in right atrial pressure. But that approach is no longer continued. Meanwhile, Kreutzer also in 1971 published the first right atrial to PA connection, and that became the standard Fontan. And then Marc de Laval, working with engineers, showed that this right atrial connection resulted in tremendous amount of turbulence, which converts to work. Whereas if you did a more uniform connection with a tube, you had much less turbulence, and this translates under higher flows to millimeters of mercury difference between the inlet and the outlet, and therefore everyone switched over to the lateral tunnel, which actually had been reported much earlier, but by Puga at the Mayo Clinic. Now, one of the challenges that we saw in those early days was that the post-op Fontan, particularly the higher risk ones, had a very difficult post-operative time. They would go into the operating room with a saturation of 75%, with a right atrial pressure of 5 millimeters of mercury, and then after the Fontan come out with a right atrial pressure of 15 to 20 or 22, but with a saturation of 98 to 100%. And they were in low output, had massive fluid retention, and many of them had very difficult post-operative courses. Some of you may remember we even had an intermittent abdominal compression device in order to help forward flow through the pulmonary artery. And this was particularly true in the higher risk Fontans with increased pulmonary vascular resistance. And John Kirkland actually wrote a paper about outcomes of Fontan in high-risk patients with a mortality of 20%. So at a meeting, I was walking with Francis Fontan and I think it was Shumway, and I asked them what they thought about this idea that we had of leaving an opening between the two just to help us through the early post-operative course. And Fontan said he was having so much trouble making sure that there were no residual holes in the atrial septum that he didn't think this would be a good idea. Now, what our idea was that if you left an adjustable opening between the Fontan circulation and the left atrium, you could shunt about 1/3 of the venous return to the left side, and provided you had reasonable ventricular function, you could reduce the venous pressure by up to 1/3 and exchange the O2 sat of 98% for a venous pressure which was reduced by possibly 30%. We discussed that with Roberta Williams and J. Jarmakani and went over the calculations, and we decided to start doing that. So we devised this adjustable ASD, which we started using in the lateral tunnel Fontan, in which we created a trapdoor connected to a very heavy proline, which was attached to the atrial wall, brought out through a polyethylene tube, and left under the linear elbow where we could get access to it in the ICU under local anesthesia and either close it or adjust or even open the atrial septal defect. And we did quite a large series and reported it in 1990. Now, one day at our CAF conference down at the B level, Jim Locke came to visit us. And we also used this adjustable ASD for the 1.5 ventricle repair, trying to avoid, again, low output states. And Jim Locke, who was then doing interventional cardiology at Boston Children's and had developed an umbrella, we presented one of our cases in discussing whether we should close this opening we had made. And he said, I don't know why you guys are going back to close it with a snare. Why don't I just put in one of my umbrella devices? At that time, they were not doing this opening, and he went back and they began their series of the fenestration, leaving a hole, which he then went back and closed with these umbrella devices. And Nancy Bridges reported their experience also in 1990, and thus the fenestration was born. It turned out that Marcelletti, for reasons of surgical expediency, described this extracardiac Fontan, and the big advantage, he was at the Vatican Children's Hospital in Rome, and the big advantage was that you didn't have to cross-clamp the aorta or arrest the heart. And one of the unintended consequences was that we discovered that one of the things that caused our Fontans to have so much trouble was cardiac arrest and cardioplegia, and that if you kept the heart beating throughout the procedure, in most cases you no longer needed the fenestration. But we still do use it in the very high-risk cases. And this is the form of fenestration for the extracardiac Fontan, which has now become the procedure of choice. And one can put in a graft with a snare around it, or create a window also with a snare, so that if one should need to adjust it without closing it completely post-op, one can do so. Or you can just make the hole and trust to luck that it'll be about the right size, and then close it later on if possible. One of the things that we saw Bill Glenn do at Yale was the axillary AV fistula, and he began to see that these Fontans, these Glenn shunt patients were so blue, and he came up with the idea, short of a Fontan, of augmenting pulmonary blood flow by doing an AV fistula up in the upper chest. It's a minor procedure. It's done without opening the chest, and one can control the amount of flow. The amount of flow goes up very slowly. And when I came to UCLA, we did a few patients who were high-risk Fontan patients in whom we were not sure that they would tolerate it, and used it as a stage towards either a transplant or towards a Fontan in patients whose major problem was inadequate pulmonary blood flow and cyanosis. Ron Day, who did his pediatric cardiology here, and his group in Oregon did a series of 23 patients in whom they did the axillary AV fistula. The O2 sat rose from 71% at rest pre-op to 84% immediately post-op, and 81% with a late follow-up after 48 months. These were all patients who were not ideal Fontan candidates, and 6 were able to go onto the Fontan. One of the advantages of the axillary AV fistula, if you have no other source of pulmonary blood flow, is that it will deliver the hepatic factor to the lungs, and thus either prevent or heal AV fistulae. And others went on to biventricular repairs or transplants. And so I think there's still a place for this. And if we were seeing patients which we see today, for example, after the hyperplastic heart Norwood procedures, who have no other source of pulmonary blood flow, sometimes after the Glenn, it's been shown that with no other source of pulmonary blood flow, you get forced into a Fontan procedure early at 3 years of age, whereas with another source of pulmonary blood flow, you can delay it to 5 or 6, and axillary AV fistula may be able to let you postpone it even further. One of the things that was mentioned by Kevin Shannon, and this is something that also Jamil and Dan Levy have brought up, is that there's a problem of getting access to the right atrium after the extracardiac Fontan. And in some of the patients, and I believe this should be done in all Fontans, is to leave a potential window between an opening in the extracardiac graft and the wall of the right atrium, which they would be easily able to perforate without having to go through the thick cortex graft, either for arrhythmia procedures or for other procedures on the left side of the heart. Reoperations on the Fontan patients have now become much more common. All the RA to PA should really be converted to extracardiac Fontans because of the risk of thrombus formation and to get a more efficient Fontan. And these procedures are frequently combined with Mays procedures for the arrhythmias and the repair of other associated defects like outflow tract obstruction or AV valve regurgitation. One of the issues is who is a candidate for a conversion, and we believe that the criteria should be quite strict. that only patients who would be good candidates for a Fontan should ever have a conversion. This becomes a difficult thing to assess, particularly in the very old Fontans. We've come across patients who are doing reasonably well with their Fontans in their 50s. And one of the problems is that as one gets older, you have an increasing stiffness of the ventricle and a slow increase in pulmonary vascular resistance, and many of them are surviving in a very low output state. And as a result, an exercise study may be helpful in showing which of these patients with mild or moderate exercise have venous pressures that go up into the 20s or 30s, and those patients probably should not have a Fontan conversion but should be future transplant candidates. Bill Hellenbrand, when I was at Yale, was the interventional cardiologist or cath person, and he did a small study of patients with exercise after Fontan, and much to our surprise, patients who seem to be excellent Fontans with venous pressures, Fontan pressures of 15 or 13 on exercise, some of them only went up to 17, 18, but there was a group whose pressures went up to 25 or 30, which you would have never suspected. And I believe that those patients are the ones that may be the future protein-losing gastroenteropathies, maybe the future cirrhosis and liver fibrosis, and need to be followed much more carefully, and perhaps may need to have a different exercise prescription. And Jamil has done quite a few patients now with exercise studies, and I think that may be quite useful in deciding who should exercise and who should not, based on what it's going to do to their liver over the next 10 or 20 years. We are now seeing more and more patients coming for heart transplants, and unfortunately many of them, because they already have significant cirrhosis, have become heart livers. We've now done 6 heart livers at UCLA, and they have done reasonably well, but it is a very challenging operation combining the two, especially when they have complex congenital heart disease with a very difficult transplant. And in addition, it's a tremendous use of resources, using both a liver and a heart on a patient whose mortality may be 2 or 3 times as high as a standard liver or a standard heart. And therefore, we are going to have to develop other strategies, either doing the heart transplant earlier, before cirrhosis occurs, or using assist devices earlier, before cirrhosis occurs, to lower the atrial pressure. This is an example of some of the challenges that we see in these Fontan transplants. This was a patient with heterotaxy, a continuation of the left IVC to the azygous vein, and before putting the heart in, had to have the azygous vein continuity connected to the right atrium, which had to be created so that the left pulmonary veins could come on the left side of the right atrium, and the hepatic vein was plugged into the Gore-Tex graft, and many of these have malposition of the great arteries. And in addition to all these rerouting plumbing problems, these patients have a tremendous amount of adhesions, which are very bloody, and trying to preserve the donor heart and have good function takes a tremendous amount of resolve and ability and skill. And looking at the experiences of heart transplantation in Fontan patients, one can see mortalities even at the 20% range. And these patients, if they are beginning to develop these high RA pressures, should be referred for transplantation as early as possible in order to avoid the combination of both liver insufficiency as well as severe cardiac problems with ascites and protein-losing gastroenteropathy. I think that over the next 5 to 10 years, we're going to be doing more and more assist devices for Fontan patients. Lee Reardon is going to be talking about that, and so I'm not going to say much except that we are going to have to develop the best approaches for very sick patients as to how this can be done off bypass, which is feasible for many of the axial flow pumps. Novel devices, I think, are going to be developed. This is the von Karman device, which has never been used in a patient, but the concept is to place an impeller at the junction of SVC, IVC, and to use centrifugal force to direct the blood through the pulmonary arteries. There has been one case of a Berlin heart in a Fontan operation where the extracardiac Fontan was patched to create a greater reservoir, and then the blood was pumped from the Fontan circuit directly to the pulmonary arteries without the use of a valve, and with a very successful reduction in right atrial pressure in a failing Fontan. If we are going to completely utilize all the available hearts, which I think is going to be likely as the number of available hearts is still stuck around 2,400 a year, and already in the East Coast, 70% or more of the patients are going to a transplant with a ventricular assist device. In the California, where it used to be 10 or 20%, it's now up to 50 to 60%. And as our congenital population grows, there will not be enough hearts for transplantation. So we are going to need a total artificial heart. Unfortunately, because resources have not been put into this endeavor, we're still stuck with the Syncardia heart, which is basically still the Jarvik heart that was used in the 1980s, and is a very loud, difficult pump to live with, and is hard to imagine as a large-scale alternative to transplantation. What has been explored is the possibility of using 2 axial flow pumps, and possibly one could use centrifugal pumps. And the problem there is balancing the flow on the left and right side, and the control of the flow so they don't get a suctioning effect. Bud Frazier has kept calves alive for up to 27 weeks with 2 axial flow pumps, and there's been one human implant in 2011 that was kept alive before a transplant with 2 axial flow pumps. Now, it's obvious that every congenital heart patient is different, and there is a need for creativity for the surgeon, both for the individual cases and both in terms of coming up with new strategies. Creativity can be defined as an ability to think of new ideas or make new things. And of course, that begs the question, what is the basis of this ability, and how can you develop it in an individual? Creativity in a surgeon, and this is just some ideas that I've had, it first of all needs an intense desire to solve problems rather than accept the status quo. Most of us tend to learn how to do what's being done well, and then will do it for the rest of their careers. The best motivation is a desire to help the individual patient, and no, in very few specialties is that true, as it is true in the adult congenital heart patient. Each individual patient is a world of its own, with its own anatomy, its own physiology, and requires a very select approach. Once you know that there's a problem, and this is true not just in the individual patient but in a specialty, the problem needs to be identified and then broken down until all its components can be seen clearly and in a new light. And then one has to have this talent of a conceptual ability to come up with a solution, and sometimes it comes out of oneself subconscious. These are examples of men who were greatly creative and innovative in their own ways. Strangely, 3 of them were Williams. William Mustard, who came up with the most commonly operation for transposition, the Mustard procedure. He started out as a general pediatric surgeon, then as an orthopedic surgeon before he became a cardiac surgeon, and came up with the Mustard procedure in Toronto. William Lumpkin Glenn came up with the idea of separation of the circulation in stages, and then Denton Cooley, who in his day did bestride the world as a colossus and was frequently thought to be one of the greatest heart surgeons of all time. At the Texas Heart Institute, there were sometimes as many as 15 patients having an operation in one day, all of them with Denton Cooley as their surgeon. and William Rashkind, who introduced the balloon septotomy in 1966. And this led, of course, to the whole field of catheter intervention. Denton Cooley was once asked during a medico-legal case whether he was the best surgeon in the world. And after a brief but considered pause, he said, "Yes, I am." And the lawyer who thought he would catch him said, "Don't you think that you're a little bit arrogant, Mr. Cooley?" And he said, "Well, you know, I am under oath." But, as Marcus Aurelius said, how many of these men, after being celebrated by fame, have been given up to oblivion? And I'm sure that many in this room already may not have heard of Denton Cooley, and perhaps have forgotten the word Rashkind. In medicine, renown is usually ephemeral, while creative contributions may be lasting and always lead to further progress. These contributions are not necessarily only contributions in new procedures or new devices, but contributions in teaching, in bringing young people along, and in the individual care of the patient. And that is what gives these contributions a life of their own. Thank you.